Hello everyone. Today our topic is humerus attachments. Let's start our topic. Subscapularis. We will go into first insertions, then origins, then ligaments. Now insertions. The multipennate subscapularis is inserted into the lesser tubercle. Here subscapularis attached to the lesser tubercle, which is multipennate into the lesser tubercle. Supraspinatus is inserted into the uppermost impression on the greater tubercle. Uppermost insertion on the greater tubercle, and then greater tubercle will have three impressions on it, that is uppermost impression, needle impression, and then lower impression. In uppermost impression we have supraspinatus, and in middle impression we have infraspinatus, and then lower impression we have teres minor. Here in the posterior aspect we can see this is the middlemost impression, that is infraspinatus, and then lower impression teres minor, uppermost impression supraspinatus. The teres minor is inserted into the lower impression on the greater tubercle. Next, the pectoralis major is inserted into the lateral lip of the intertubercular sulcus. The insertion is bilaminar. Pectoralis major. Latissimus dorsi is inserted into the floor of the intertubercular sulcus. Floor of the intertubercular sulcus. Here to remember the things in the uppermost area is a lady between two majors, that is majors are pectoralis major and teres major. In the between, that is latissimus dorsi. The mnemonic is a lady between the two majors. Next, it is the anterior part, and then teres major is inserted into the medial lip of the intertubercular sulcus. Deltoid. Next, the deltoid is inserted into the deltoid tuberosity of the humerus. Excuse me. Coracobrachialis is inserted into the rough area on the middle of the medial border. This is medial border. Coming to the origins, we have brachialis, which is the largest and chief muscle of the humerus, that is arises from the lower half of the anterior medial and anterior lateral surfaces of the shaft. Part of the area extends onto the posterior aspect. The part of some area will be extended on the posterior aspect to medial head of triceps brachii, and this is brachialis. Then brachioradialis arises from the upper 2/3 of the lateral supracondylar ridge, extensor carpi radialis longus arises from the lower 1/3 of the lateral supracondylar ridge. This is lateral supracondylar ridge. The pronator teres arises from the lower 1/3 of the medial supracondylar ridge. This is medial supracondylar ridge. Next, superficial flexor muscles. These are the flexor muscles. which arises from the common origin from the anterior aspect of the medial epicondyle. This is called the common flexor origins. The superficial extensor muscles of the forearm and supinator have a common origin from the lateral epicondyle. From this extensor origin, this is called the common extensor origin. Next, anconeus. Anconeus in Greek means elbow, arises from the posterior surface of the lateral epicondyle. This is lateral epicondyle in the posterior aspect, anconeus. Triceps brachii. We have two origins of the triceps brachii here, that is lateral head of triceps brachii and then medial head of triceps brachii. Lateral head of triceps brachii arises from the oblique ridge on the upper part of posterior surface above the radial groove, which its medial head arises from posterior surface below the radial groove. Next, we go to the ligaments. Capsular ligament of the shoulder joint is attached to the anatomical neck of the humerus, except on the medial side, where the line of attachment dips down by 2 cm to include a small area of the shaft within the joint cavity. The line is interrupted at the intertubercular sulcus. It is interrupted at the intertubercular sulcus to provide an aperture through which the tendon of the long head of the biceps brachii leaves the joint cavity. Next, capsular ligament of the elbow joint. Capsular ligament of the elbow joint is attached to the lower end along a line that reaches the upper limits of the radial and coronoid fossae anteriorly, and then the olecranon fossa posteriorly. So this fossae within the joint cavity, medially the line of attachment passes between the medial epicondyle and the trochlea. It passes between the medial epicondyle and trochlea. On the lateral side, it passes between the lateral epicondyle and the capitulum. Here, between the lateral aspect, it passes through the lateral side, lateral epicondyle and capitulum. This is lateral epicondyle and this is capitulum anteriorly. The three nerves are directly related to the humerus and are therefore liable to injury. Yeah, here is the main topic, that is the nerves related to the humerus, which are nearer to the humerus, are more liable to the injury, means more caused to the injury, means more prone to the injury, that is axillary nerve. These are the three nerves which are related to the humerus, that they are axillary nerve, radial nerve and ulnar nerve. The axillary nerve at the surgical neck, this is present at the surgical neck, and the radial nerve at the radial groove, and the ulnar nerve behind the medial epicondyle, which is prominent. Okay, these are the three nerves which are more prone to injury on the humerus. Ossification. The humerus ossifies from 7 primary centers and then 7 secondary centers and 1. Primary center. The primary center appears in the middle of the diaphysis during the 8th week of the development. The upper end ossifies from 3 secondary centers, one from the head, first year, one from the greater tubercle, second year, and one from the lesser tubercle, fifth year. The 3 centers fuse together during the 6th year to form one compound epiphysis, which fuses with the shaft during the 20th year. The epiphyseal line encircles the bone at the level of the lowest margin of the head. This is the growing end of the bone. The lower end ossifies from 4 centers, which forms 2 epiphyses. The center include one from the capitulum and the lateral flange of the trochlea, first year, one for the medial flange of the trochlea, 9th year, and one for the lateral epicondyle, 12th year. All 3 fuse during the 14th year to form another compound epiphysis, which fuses with the shaft at about 16 years. The center for the medial epicondyle appears during 4 to 6 years, forms a separate epiphysis, and fuses with the shaft during the 20th year. Who had fused their shaft can comment in the comment box. Next, clinical anatomy. The common site of fracture of humerus are the surgical neck, shaft, and supracondylar region. 3 places: surgical neck, shaft, and supracondylar region. That is here. Surgical neck, shaft, and supracondylar regions here. Supracondylar regions. Supracondylar fracture is common in young age. It is produced by a fall on the outstretched hand. The lower fragment is mostly displaced backwards so that the elbow is unduly prominent, as it's shown in the diagram here on the outstretched hand. This fracture may cause injury to the median nerve. It may also lead to Volkmann's ischemic contracture caused by occlusion of the brachial artery. This is Volkmann's ischemic fracture, which is caused by the occlusion of the brachial artery. The 3 bony prominent points of the normal elbow form a triangle in a flexed elbow and are in a one line in an extended elbow. Here, 3 bony points of the normal elbow form a triangle in a flexed elbow, and are in one line in an extended elbow. The humerus has poor blood supply at the junction of its upper 1/3 and lower 2/3. Fracture at the side show delayed union or non-union. The head of the humerus commonly dislocates inferiorly. Here is the dislocation of the humerus. This is an inferior dislocation of the humerus. Means when the humerus is at the normal position, due to outstretched hand or something happens at the shoulder joint, the humerus will come into the inferior aspect, so that the joint will be more unduly for the work.